Good afternoon. I'm Corey Plank. I'm the manager of the city's Strategic Initiatives Division. And I use she, her pronouns. Happy Pride Month, and thank you so much for joining us for this presentation of Patient No More. And special thanks to Dianna Fraser for this incredible film. We want to take a moment to thank our city council, both past and present, for their support of this work of the LA County Lesbian, Bisexual, and Queer Women's Health Collaborative. And tonight we're honored to have two of those council members with us who've been staunch supporters of this work. And you'll hear a bit from them in just a moment. I want to introduce council members Lindsay Horvath and council member John Erickson.
Good afternoon, everyone. Thank you, Corey, and thank you to everyone who made today's event, a virtual event, possible. We know this event happens through the partnership of the LA County Lesbian, Bisexual, Queer Women's Health Collaborative, the Iris Cantor UCLA Women's Health Education and Research Center, in partnership with our city of West Hollywood, and of course with Cedars-Sinai, which is an incredible partner in the work that we do throughout the region. And we thank all of you for participating in this upcoming panel discussion. This has been an important addition to the work that we do in our community, and these community partnerships help us thrive in community. It's important for this event that we're doing this event in partnership with in recognition of Pride Month, and we hope that it continues to be informative and helpful for you long past our celebration this month. Without further ado, I want to turn it over to my colleague, Councilmember John Erickson.
Thank you so much, Councilmember Horvath. Hello, everyone. It's so great to be here with you all. Councilmember John Erickson. I want to thank all the filmmakers and all the partners again who have been a part of this project.
Councilmember Erickson, you have your finger on the mic.
I have my finger on the mic. Well, I'm on my phone, so I don't know where we're good now. Great. Lindsay just said we're great. So want to thank you all for all of your help and participation in putting this event on. I have the individual that helped introduce me to a lot of this work, Ivy Bottini, right behind me right here. Many of you will know who she is, who has fought for many of these issues for quite some time when she was alive, and her legacy lives on through a lot of the work that's been going on here. So thank you all. Happy Pride Month. Thank you for being the best part of our city as we continue to advocate for these critical issues and important causes. And I now have the great pleasure of introducing today's moderator for the event. And it will be moderated by Janet Pregler, Dr. Janet Pregler, who's a professor of clinical medicine, general internal medicine, and health services research, and is director of the Iris Cantor UCLA Women's Health Center, and is the Iris Cantor Endowed Chair in Women's Health, David Geffen School of Medicine at the University of California, Los Angeles. You have all the great titles, all the great names behind you. And funny thing, when I started as an intern at the city of West Hollywood, this group was actually the first group that I sat in day one and took notes for. And now I'm a council member there. So it's great to see how amazing this group has just been doing so much great work for the county. Janet is one of the founding members of the LA County LGBTQ Women's Health Collaborative. And if you don't know her, she's an amazing advocate and person altogether. So Janet, without further ado, after you.
Thank you so much. All right, I am going to ask the panel to come on screen so people can see you. And again, I want to just do two quick thanks. First to Jenny Ivanova. She is our techno mage, and she really made this happen today. Thank you so much. And the second is to the city of West Hollywood. You know, as you've seen in Dianna's wonderful work, 10 years ago when we started this, there were actually a lot of people who questioned, was it necessary to think about LGBTQ plus women in the healthcare space? And, you know, I think that we all agree that it absolutely is. So what I'm going to do first is I have one question for each of our four amazing panelists to introduce them. So I'm going to ask the question, ask them to introduce themselves and give their reactions. Then we'll have an additional question for everybody to chime in. And then we'll be taking questions from you all to hopefully shed some light on these really important issues. So I get to start with Dianna Fraser, the director, producer from Pigtail Brigade Productions, LLC. And Dianna, when we were batting this back and forth, I shared with you that about 30 members of our Los Angeles County Lesbian, Bisexual, and Queer Women's Health Collaborative had viewed your work. And they brought up something that apparently most people didn't ask about. So, one of the things that rose to the top really was the title. So the title of your film is Patient No More. And we had a lot of people kind of batting back around, well, what does that mean? And where were you going with that? And so forth. So please introduce yourself and then tell us a little bit about how you came to that title and sort of what it's developed to mean for you.
Sure. Hi, everyone. My name is Dianna Fraser. I use she, her pronouns, and it is a pleasure to be with you. Happy Pride to all who celebrate. And I just kind of want to say to start with, it means so much to be in spaces with powerful potential change makers in this particular healthcare field. And so I'm really glad you're here today. And this is why I do this work, because these spaces give me hope. And I know that there are hardworking people who are trying to make this different every single day in the trenches. And this cannot happen without you. As it relates to the title, so I snagged the title kind of early on in the proposal process. I was making an indie film on $10,000 in my spare time. So a pithy title is kind of like the cliche of indie cinema, but you lean into that. And so it was pithy. It, I think, nicely encaptured or encapsulated the conundrum that queer women encounter when they seek medical care. They're either told to be patient and sit down and we'll get to you. Or if you fight against that, right, then you're labeled as loud and annoying and brash, that's the word I'm looking for, brash, and it's a problem, right? And so often you leave that care facility or that particular provider. And so you have this catch-22 of you want better care and you want to advocate for it, but you don't want to be told to sit down and shut up or have to lose your care provider and then have to start the journey all over again, right? And it's also a bit of a pun, which I'm not going to lie is a soft spot in my heart. So it ticked all the boxes that I needed it to tick for an indie film. But it seems to also, I think, have communicated the message that this is a conundrum and one we need to address.
Thanks, Dianna. And I have to agree. I mean, the hope was there, but I also heard the voices certainly of many of my patients and what they've expressed. So next, I'd like to turn to Dr. Katie Duffy, my longtime colleague, who directs the Audre Lorde program at the LA LGBT Center. And we heard in the film from Dr. Haley Vizet about how healthcare really has been heteronormative, binary. But I think one of the things that we've talked about a lot is how healthcare, and in particular healthcare training and research, has been grounded in a gendered model, and that is men. So as an example, although heart disease is the #1 killer of both women and men, the physicians here know that we treat heart disease based on studies that were done in people who identified as men. And we really haven't had as much research on women. So Katie, I was hoping that you could talk a little bit about, as you've thought about developing a program for individuals who identify as women within a LGBTQ plus care space, what were you thinking about? And then how can we learn from that in the broader healthcare system?
Yeah, thank you. And that was a great documentary. I really enjoyed it. I appreciated the work that went into that. I use she, her pronouns. So our organization traditionally started as an HIV STD clinic, and it emerged out of a crisis that people were dying. And much of gay health throughout the years emerged in exclusion of women, and people who identified as women. Though lesbians, obviously, as we heard, were such a big part of responding to the HIV crisis, there was not much of a response, and has not been much of a response for lesbians and for queer identified women. And so I was hired to build our program. This has long been a mission of the LA LGBT Center, but it's been hard to put into action. And so creating a home for queer identified women within this space has its own unique challenges, similar, I think, to what it could be at a clinic that's not necessarily queer focused, but it's making women feel welcome in our waiting room, in our exam rooms, in our education material, advocating for the issues that affect women. And with HIV, there's a lot of funding. There's not a ton of funding for queer identified women. It doesn't bring in the grants. It doesn't bring in the money through our pharmacy with the antiretroviral. So how do you make a case that this population is really important and have been left behind, and that there's no one paying attention to them? And that's the challenge, I think, because I'm at a federally qualified health system where we rely on funding. And so that's what I set out to do when I was hired here. And it's little by little. It's reaching out to queer identified women, inviting them into the space, and then putting our money where our mouth is, and really doing our best to listen. And for me, what is the core of the work that we do is providing trauma-informed care and trauma-informed pelvic care. Anybody who has had a speculum exam or has undergone a cervical cancer screening understands the medical trauma that can go into that. And so if we are approaching this population from that lens of being trauma informed, from the moment we start talking to the first time we put our hands on the patient to when we get to an intimate exam like a pelvic exam, I think that's how we grow this. We grow it from a commitment to serving this population, and then making strides within the exam room to make them feel safe, to make them feel prioritized, and to keep them coming back.
Thank you. So now we're going to chat with Dr. Allison Cedeso. She's a PhD, a psychologist. She's an assistant professor at the University of California, Santa Barbara, who does research on queer women's health. And to me, it was really interesting to see the discussion led by Jessica Easter, who was the hospital chaplain, who had, I felt such powerful dual experience as sort of someone who works in the healthcare system, but who also had experienced it. You do research on intersectionality, so sort of bringing out a lot of the things that we heard discussed. So my question for you really is to talk a little bit about that. So when we have individuals who are in a system that's heteronormative, but they're not heterosexual, that's in a system that is binary, but perhaps they're not binary, that they're in a system that's based on research done in men, but they don't identify as a man. And then layering on top of that, issues about how they may identify from an ethnicity perspective, as an example, or others might identify or misidentify them. If you could talk a little bit about how that fits into this idea of how we can better care for women.
Sure. It's a big topic. It's hard to know where to start. But what I would say is that in my research, so I am a psychologist, and I really set out to learn more about behavioral health. And in doing the work, it was just, like every study that we did, regardless of what we were examining, ended up being about trauma. And it also was about the ways that people cope with trauma in accessible ways. And so, so for myself, I didn't start out doing research on substance use or alcohol, but because it came up in every single study, recognizing that like, hey, there is a pattern here. Sorry, my dog's in the background. There's a pattern here, and it's something that I have to pay attention to. And so one of the studies that we're initiating in the fall is really looking at the ways that like daily stress impacts like mental health or negative affect that then drives alcohol and cannabis use, but all among Black and Latinx sexual minority women. And so for us, what we're finding is that oftentimes when queer women of color are losing like connection to ethnic racial community, that's where we see more of the challenge. And some of that is because, you know, I would say is for myself, right, coming into, you know, the world as somebody from Los Angeles, East Los Angeles, as a person of color, that the ways that I learned, like, you know, what race meant to me is my lens completely. And so, you know, being a queer woman like that helps. That's really, you know, wonderful, beautiful part of who I am. But the way that I learned to understand the world and navigate the world was as a woman of color first. And so I think for us, what we're starting to see is just like that danger that lies right at that intersection when you do lose connection to ethnic racial community. And so one of the things that I've started to do that's really exciting is working for the California Department of Public Health and their statewide initiative to address health disparities among queer, trans women, and non-binary Californians. And so the biggest thing that we're seeing is the importance of really focusing on ground level community initiatives. And so oftentimes, right, like we think like, okay, how do we create better access to medical care? Or how do we create better access to X, Y, and Z? But a lot of the models, what Katie was talking about, are related to HIV. And so it's the idea of like, okay, but what do we, when we talk about women's health, or we talk about, you know, sort of like health issues that are specific to folks related to the ways that like, yeah, sex functions in the world, like, you know, sex and gender, that we have to pay attention to things that are not just about HIV, but other things as well. And so what we're hearing from our community members is like focus on housing, on economic issues, things related to transportation and mental health, trauma, coping. All of those things matter so much. And that risk that there is a link between that and your physical health. And so for myself, even when I think about the substance use work that I do, so much of it is really prompted because I know how much it's connected to cardiovascular risk. And you just said that, right? Like the heart, you know, heart disease being the thing that, you know, is the #1 killer. And so for us, it's that ability to really like pay attention and to be as connected to community as possible. But that means to like also really be driven and like center the voices of women of color in that work. Because we know that if we're really focused on race and we're also focused on income and socioeconomic status, then we develop programs and we understand like ways that we can link queer trans women to access like services that then benefit all queer and trans women.
All right, and then finally, I get to introduce Dr. BJ Reimel. She is a gynecologist, a faculty member at Cedars-Sinai Hospital System, a gender-affirming surgeon, as well as a GYN oncologist. And when we were talking about screening this film, you know, again, to me, and Dianna reminded me, there are 17 individuals in this film, all from Minnesota, which I thought was interesting. You know, for me, I was thinking, wow, you know, there's so many different voices represented here, but I was wondering from your perspective, we talked a little bit about, are there voices in this community that you felt, you know, might be added? And also just in terms of the topics that were covered, are there additional things that strike you or that we should be thinking about in terms of lesbian, bisexual, and queer women's health?
Thanks. Well, as you mentioned, I'm primarily a gynecologic oncologist, and that specialty, for those who don't know, arose out of a group in the 1950s who were gynecologists primarily, who felt that the surgeons who were refusing to treat their patients for gynecologic malignancies because they were women were being unfair, and that they wanted to develop a specialty devoted to the care of the unheard, right? The feminine voice that was being unheard. And these women were not offered surgery or chemotherapy because they were considered too weak to undergo it. So fast forward about 70 years, and now the people that go into this specialty are primarily focused on still voices that are not heard. And my privilege in getting to work in both in the transgender program as a gynecologic surgeon and also as a gynecologic oncologist taking care of folks who have cancers of the reproductive organs has helped me a little bit see some of the voices that I would say maybe don't get heard. And one of those voices that I see fairly frequently is the role of gendered cancer screening on the ability and the willingness of folks to take it on. They may not understand what parts they have after gender affirmation surgery, and so are unsure about what screening applies to them. When screening is gender biased or gender based, it's very difficult to understand where you fall in that if you identify as a woman, but you've had a mastectomy because you're really non-binary, there's no rules. So we are working, and other places are too, but we're working here on doing organ inventory to help folks really understand what they still have or what they were born with, and then what needs to be screened for what cancer and how often. And in gathering data about our SGM and transgender populations, as well as all of our sexual orientation populations, we can get better data on how often you really have to do this stuff. Because right now it's all cis het normative risk profiles, and that may not apply. As the people in the film so eloquently pointed out, that risk is really an individual perspective. And it also, risk can only be assessed by the person who's taking it on, and also a lot of math. So it helps to have more numbers to make that a better opportunity for people to make that assessment. So we're working on that actively now, and I'm excited to see the voices of our folks who will be contributing their experiences to our ability to help treat future people.
Yeah, and I'd have to just comment, I think too, certainly we've seen that, and it was so interesting you said it that way, that in the heteronormative system, we also had a lot of individuals who identified as cisgender, lesbian or bisexual women, who also felt that they didn't really fall into that screening paradigm. Is that something that you also still find?
I do. The data on HPV risk for women who have sex exclusively with women versus women who have sex mostly with women versus women who have sex with men and women is very poorly defined. There are actually only 3 large-scale studies, all of them done in Europe. We can do better than that, but we don't capture that data in the United States very well. And so further research is really necessary to count these voices to make them more visible so that we can offer screening that's appropriate and not screening that isn't.
So the last kind of question or comment that I would make is that I thought that Venus de Mars was so eloquent in terms of advocating in the healthcare system, and relevant certainly for what was very important to her, but also relevant to I think all patients. One of the things I feel like we're trying to learn, particularly in the last 2 years, is that advocacy is not just for the people who are experiencing a disparity or primarily for them, but it really has to include everybody. Katie, I'd like to start with you on this one again, because you've really thought about the health system perspective a lot. Where should allies and advocates, be starting? What should they be doing to really move the needle on this?
In terms of healthcare provider?
I think just everyone, right? Because we heard as an example from Venus de Mars about what it was like to advocate as a patient. But, I think anybody sort of in the world, how can they help us do better in healthcare in this area?
Yeah, I mean, if I'm going to start with healthcare providers, I think that the first thing that any allied healthcare provider can do is to normalize asking about sexual orientation and gender identity in the patient encounter, even if, to your knowledge, you don't have any queer identified patients. Because first it starts patients thinking, oh, these people exist. And secondly, it creates this space where if there is somebody who maybe couldn't have or wouldn't have felt safe divulging previously, now they do. And I think that's an obligation of healthcare providers. And I know that many are reluctant to ask. I've been in that situation myself, because you don't want to offend, or you don't want the person who you're asking to get irritated or mad at being asked the question. But I think that that's the number one advocacy thing that we as healthcare providers should do. Always ask, don't assume, and create that space for somebody who's just waiting for the question. And I think, in the general population, I think I have to acknowledge the privilege that I have in working and living in Los Angeles and working at the LA LGBT Center. So I think when I advise or beckon people to become advocates, it's from this place of safety where I'm not risking my job. I'm not risking anything really by being here. And that is a place of privilege. I mean, there's places in this country right now where parents are being brought to Child and Family Services for giving their children gender affirming healthcare. Imagine that. And that's so far from my reality that I think what people need to do in different situations in different states is very different and requires a different level of courage. But I think wherever we are, hopefully there can be an acknowledgement that those kinds of laws and what just happened in Arkansas are brutal and they're inhumane. And even if we can just have that as a point of agreement, is that trans kids deserve to live, like just starting there. In places here where we have millions of dollars that were just allotted by the legislature to support this population, I think that the work is different. It's more nuanced, but it's still there. I think there's still a call to action to show up, to be in solidarity, and to be allies. But it's certainly less profound or pronounced than it is in other parts of the country.
And Allison, I'd be interested in your perspective and also from your work. What can allies and advocates do to improve our healthcare system?
Yeah, I feel like sometimes it's mandates, honestly. I think I had the best experience when I was out doing one of the trainings for the collaborative at Women with Infant Children WIC, where we literally were like, this is how you ask about sexual orientation and gender identity. Here are scenarios that, like, if you're a provider, this is the way you ask or you start a conversation. And I feel like that happened at WIC and a couple of other places I went out and did presentations, because they have state funding and there was a state mandate that you had to ask about SOGI. And so, I think sometimes it's like, intentions are amazing and we should always, support that, but I think they're micro level. And I think sometimes you need the larger system structural change, and that includes state mandates. Like what we're seeing happening in Arkansas, that's awful, and the other things in Texas, like it's horrible. But that's because, there's state, laws or state mandates that are happening that prevent people from giving care in the ways that they want to or should. And so, yeah, I think that allies, I would say that you do your best in California to ensure that we continue to have what we have and that we have even more. I think this collaborative advocated for that 17.5 million that CDPH is invested in, in sexual minority and non-binary Californians' health. So it's incredible. And that only happened through advocacy. So I think, it's great, one-on-one to have good intentions and do good work and, follow the policies. But I think also just really engaging in advocacy as much as possible.
And how about you, BJ? What do you think would help? What should the allies and the advocates be doing to help your work?
Vote. Really carefully and thoughtfully in their own lives to create a commitment to open-mindedness and to try to be aware of ways in which they can open their door a little wider, even if they think that they know it all and are totally aware of everything. The world is constantly changing and evolving, and being willing to pick up new skills and new ideas is really a great place. So I would really focus on that.
So I'm going to invite people to submit questions now, and Dianna, while we're waiting for those to come in, you know, I thought it was interesting that BJ referred to the world as changing, because it certainly has for me. And, you know, again, I think the docs here, you know, I really identified with Dr. Deb Thorpe, because that's when I trained, like way back in the day. So Dianna, you know, since you've produced and directed this film, and it's sort of been out there, and you told me you've done many events like this, what sort of changes are you seeing? Are you seeing different answers to some of these questions now compared to when the film first came out?
Well, I'll start by saying my hope and dream for this film is that it's obsolete tomorrow, right? Like, that is a historical relic that we don't ever need to refer to again. That's not really the case right now, I'm very sorry to say. Honestly, between when I proposed the film, got funding, and then like made it, very little changed. And I think that's something that people really have to understand, because you have seen a lot of different change in understanding and knowledge of gender issues, for instance, gender identity over the last 10 years, in particular, like even since I came out. I grew up in rural America. That was a whole different ballgame. But like, you've seen certain things change very rapidly. Healthcare has not. And I'm not saying that because it's not possible, but because it's really important to acknowledge where you're starting from. And I think, like Haley talks about in the film, people still think of queer healthcare as an optional situation. It's a specialty you can go into. It's extracurricular, as opposed to being a large majority of our patients now, and a population that desperately needs to be served well. And so I haven't seen a lot change, but what I can tell you is I think the advice that people are saying to take on seems to be pretty consistent, which is great. There's definitely like the infrastructural and the legislature pieces, which is super, super important. And then on the individual level, what I'm hearing people say a lot of is this has to be like intergenerational continuing education, right? Because so much of medicine is hierarchy, whether you want it to be or not, it is. And so you can't just have these medical interns or people who've been fighting the good fight in their own lane, right, be the only people doing this. You have to have this coming top down and out and through. I hear people saying, like, correct your colleagues. It's not rude, it's educational, right? If you were doing something incorrectly in surgery, you would be corrected, right? You're doing something that actively harms your patients. Stop. Learn how to do it better, right? I think that's a really important thing to bear in mind. I think this is a pet peeve of mine, right? But people will always kind of go off about the alphabet soup, or like pronouns are so hard. And I just candidly want to turn to the medical professionals and say, y'all memorized so many medical textbooks. You got this. I promise you, you can do this too. And it means so much. It is such a small thing, but it is not small impact. And I think that's important to remember. And also, I think like two things that I keep telling people, just like on a personal level, is one, bring advocates with you. Like, you don't have to go to a doctor's appointment alone. That's something we've really integrated into trauma care, but it's not something we've integrated into other healthcare. And the thing is that a lot of queer women have experienced trauma in health spaces, right? Like, this is a traumatic space that they are coming into for them. And so being able to lean on people who love you and care about you, or can help you like write down your questions in advance so that you get your needs met, that is a totally fine thing to do, even though it doesn't feel permissible. And the other thing is to submit feedback forms. You can do that for every single physician you see. You can see that for any care provider. And like most other fields wouldn't, like, you wouldn't have a bad service and never get a bad review, right? And so like, those are ways to make your voice heard and your concerns addressed, because the reality is, we talk about this in lots of trauma spaces. We talk about it a lot in sexual assault. If no one says anything, it doesn't change. And that doesn't mean that the burden should be on queer women to make this change. That's the crappiest part of the whole process, right? Is that the people who are being actively harmed are the people who like need to be the loudest sometimes. Erin McQuaid talks about that too. Like, it's a double-edged sword. You don't need to do it all the time, but when you do have the wherewithal, it makes a difference even if you don't see it immediately. And so I think just remembering that you have agency and power, you have dignity, whether or not people have treated you as such in those spaces, is really, really critical to being able to continue the fight and to change the way that people talk about it and educate about it.
Yeah, and I will just say, and I know BJ also teaches in the medical school, I'm seeing a palpable change. It really in the last 2 to 3 years in terms of what all our students are expecting to be taught in this space. And it is a change. It is that transition from what we heard from Dr. Haley about it's kind of an optional noontime talk. You know, and like you say, I mean, until the culture changes that like, hey, you're not teaching me right if you don't teach this, I think that we're not going to see the change, but at least at UCLA, I feel like we're seeing that change. I don't know others here who are teaching now. Do you feel that change with your students? Do you feel that they're kind of demanding this information, no matter how they identify?
I'm not sure I'd go so far as to say demanding, but I do feel like they are listening. And I agree, there's been a definite shift in the youth coming through, the interns, the whole group of people being much more receptive to what we're trying to put out there. Like, and I'm not having to redefine things like trauma-informed care, which I feel like 10 years ago, people were like, oh, tell me about that. No one ever said that to me. And I'm like, oh, now they come in knowing that, right? We say a model of reproductive justice or restorative justice, and people, oh, I understand that. I feel like I've spent the first 10 years of teaching medical students teaching about justice, because we really didn't spend enough time talking about how we need to do something different. So I feel like there's definitely an improvement, and it's not perfect. We have, light years to go, but there's some really great things that are definitely happening.
And what about you, Allison? Are you seeing this in your teaching?
Sure. Yeah, because I train clinical counseling and school psychologist. But I would say it's an interesting thing where they're more advanced now than I think most faculty. And so a lot of folks coming in. And I think it's been really beautiful to see like how much more research there has been happening. And so I think that means that people come and they've like done some reading. And I can see now like we have way more non-binary trans students, a lot of queer students in the doctoral program that I teach in, and we're not a very big program. But that's also because we have 3 faculty members who are out on, and we do, or at least a couple of us really do research in that area. So we bring in those students. But yeah, I would say that especially related to like gender diversity and really understanding the nuances around gender and sexual orientation, like absolutely, I've seen a big growth there in the last few years.
And Katie, any comments about sort of the training element or the role of students?
I was thinking about this because we're in a different position in that we have a lot of students and residents who want to rotate here and are contacting us. And it's difficult because we have a vulnerable population, and I'm trying to find the balance between our obligation to train the next generation of providers to be LGBT competent and protecting our patients who have already a mistrust over the medical system. And I haven't yet come up with what that looks like. But I know that the interest is growing as we're being contacted even more and more, which is a good thing. And I think that this kind of training is beneficial to everybody, but I have a little bit of reluctance to have people rotate through unless this really is their passion. Mm-hmm. And that's just that's not the academic in me or the doctor in me. That's more of, the protective, my protective instinct for my community.
Well, and I'd say too, though, I to me, that also is the doctor, right? You have that one-on-one relationship with a patient, and there, you don't want to impinge on that. And sometimes that does counter the educational mission. Yeah, where the balance is. On the theme of students, we have a question that was submitted. which I'm going to read. As a student applying to medical school, I've been told many times not to mention my sexuality in my medical school application. Similarly, I've been told not to mention overcoming mental health issues. How can we overcome this stigma as incoming medical school students who will be the future of medicine? So I'm just going to throw it out to our panel here. Katie, I'll go back to you. So if you were advising this student, would you advise them? Don't talk about your sexuality?
I would say, and I don't know if I'll agree with myself in a couple minutes, but I would say don't go to a place where you can't feel safe. Because as a medical student, you're not empowered in any way. The traditional hierarchies exist, and you're not going to be able to change that system, and your mental health suffers during medical school. And so seek out a program that you're going to feel safe. The time for changing and busting up systems will happen, and that's when you graduate, when you have more of a voice. But I would be very protective of somebody who got into a program and felt like they had to lie. And I don't underestimate that they could mobilize other students and they could make change, but I worry how that would look for them. And in my own medical education, that's with residency, I was very upfront, and I watched facial expressions because I knew what residency was going to feel like. And if there was any hesitation about who I am as a total individual, then it wasn't the place for me.
And Katie, when time-wise were you doing your residency?
So 2010 was when I went to medical school. I went a little late. So 2014 was when I started.
Yeah, so that's not a long time ago.
No.
Yeah, that's not like me in 1980.
Right. And I think that people who applied years before had different experiences, but it's important to feel safe.
Yeah, and Allison, how would you comment about that, and particularly the issue around talking about mental health in applications?
Well, the first thing I was going to say is that, like, I was told explicitly not to talk about LGBT issues in my application. Like, I was very out when I was going to apply. And so
I have to ask again, Allison, when was this?
I started, I think, in 2003.
Okay.
So it wasn't so long ago, but it was long enough. And I was told just to focus on the Latinx thing. And I was like, okay. And that was fine. I did that, but it took me on a really different path. Like, I had to really figure out how to get back here. And thankfully I did, but I feel like, that things could have been different much faster for me had I just stayed true to what I really wanted to do. So I think similar to what Katie said, I think maybe choose states where there are some pretty basic LGBT protections, so that at least you're protected that way. It doesn't mean that your med school is going to necessarily respect all of that, but at least you have some basic protections, basic legal protections, and around housing and other things that are super critical. Around mental health, it's interesting because I think I literally direct a racial healing trauma clinic, and I would say that the folks that we bring in, right, maybe I think we admit less than 2% of people that apply to our doctoral program. It's very competitive. And I think that you absolutely, once you're in the program, can definitely do some advocacy, but I would say getting into the program, if there's a certain story there and a narrative that's very much matched to the work that you want to do, then sure, but people have their biases, absolutely. Because they know that getting through the program is it's arduous. It's a really hard process. And so, unfortunately, people are going to do their admissions review based on those biases. And so it's not something that I would necessarily recommend unless it was very much tied to the research you plan to do. And so I think if you could make that connection to the work, then you do it. But otherwise, I don't know that I would necessarily recommend it. Not because I think that there's anything to be ashamed of, but because I do think that biases around mental health are just so strong that I think I wouldn't trust that reviewers would really see you the full picture.
Right. And as we know, even if they might think they're trying to, right?
Yeah.
Because there's that whole implicit. And then BJ, obviously you advise medical students and residents. What advice would you give to this individual? Would you have them talk about their sexuality and or mental health?
Yeah. So I think I think it's probably going to come out what the sexuality is when they have their interviews. So, or usually people offer that information in one way or another. But I would say I would agree with what Katie said, like find a safe space. So you definitely want to be at a place where they're going to accept you for who you are. So if that's important to you and it was to me, in fact, I dressed and behaved a little differently than I look right now to make sure everyone was really certain that I was queer, aggressively so. That really worked for me. Not saying it has to be what you do now, but the shaved head and the piercings really helped me at that time in my life.
Okay, and I have to ask this, what year was that?
So I got into my residency in 2003 and my fellowship in 2007.
Okay.
So it wasn't that long ago. But I remember explaining to my fellowship director that I was pregnant with my first child as a fellow. And he was like, I didn't even know you could do that.
Oh. Yeah.
And I was like,
yeah.
Did you draw a diagram for it?
We're OBGYNs.
Well, yeah, that's what I love. I mean, yeah.
So I just remember thinking like, gosh, you have so much to learn from me. And I have so much to learn from you. Like, we're just going to see how this goes. He ended up being one of my best allies, like stood up for me when nobody else would. But that was my experience. It's a one-off. Like, I can't say that that the whole thing would have been okay with somebody else. So about the mental health question, I generally counsel my medical students not to bring health at all, stuff anything into their stories, because in medicine, our biggest biases are that, as the patient pointed out, we feel responsible for what other people are doing or choices that they make. And we think that we know when we don't know anything. And that bias is deep. And it's probably the deepest bias I think we hold in medicine, is this concept that we know something that we can do something about. So I would hold back on any health thing and just make your medical school application about the things that bring you joy and the things that you bring to this without putting any sort of medical ease in it at all.
And so, Dianna, I'd be interested, because again, you do these sessions all over the country. Do you hear different answers to this question in different parts of the country in terms of trainees talking about their sexuality?
Yeah, I think Dr. Duffy's point is really important. Safety is your first concern always. That's always, I think, true in the queer community. And I don't want that to have to be the first thing, but also I'm really glad that it's the first thing everyone always brings up, right? Because I think there's care in that action, right? And saying, take care of yourself first. So yes, this is broad swaths, right? Not everywhere is exactly the same, but generally, right, more rural areas, more suburban areas tend to be a little more dicey in terms of the biases that people can hold and act on. Urban spaces tend to be, I would say urban younger spaces tend to be less full of those biases, but there are a lot of intersectionalities, as we talked about through the film, and also conversation, right, that comes into those lenses. So it's not really a one size fits all conversation, but I think safety is the first most important part. The story that I tell is I had to come out publicly making this film, which wasn't something I was particularly thrilled about, not because I'm ashamed of who I am, but because this is my life. This is a private part of me that I want to be able to share when I want to share it, with whom I want to share it. And as we're seeing, right, outing people is like a whole media gamut right now. But safety was the first consideration. So to me, it was how do I want to share this? It was a whole, like, if I didn't come out, then it would appear as if a straight person had made this film and that was a problem, right? It's sort of a problem. It's not always a problem. It could be a problem, right? It's that nuance there that becomes complicated. And so I think when you're talking about your story and sharing your story with people, if you feel confident doing that, that's your story to own, right? I do think it's important to consider your audience, what biases they hold, how that affects your safety, and what support systems you have, right? within those spaces, but it will never be a one size fits all situation. And I can't give like a, this is the way to do it necessarily. And I don't think anyone here has tried to do that either. But I wish you the best of luck. And I hope that you find what you're looking for in medical school and that you are also one of those people who will change the system in time.
Absolutely. So we had another comment, and it said, can I add a comment to this question? I'm also applying to medical school this cycle and have been thoroughly upfront with who I am, my queer identities, my low income struggles, my Blackness, etc. I know many of my friends who have applied and gotten into several schools being open about who they are. You want to go to a school who fully accepts who you are, or it will be daunting on your mental health to feel like you have to hide who you are. I know it's an overly complicated topic. And then actually this individual said, I'd be happy to connect with the other person. So I'm hoping, Jenny, that you can let them know if they're open to send their info in and we can swap. And again, I do think there's that balance because I work with a lot of medical students and advise them. And I think being authentic to who you are is so important. But I think also what BJ said, and I've had this discussion with some people, getting to be a doctor is so powerful. So you could certainly picture someone who would say, I want to get to that doctor point. But as you said, then you really are concerned about the safety of someone who's going somewhere where they don't feel that they can be open. It feels like that's a really tough situation. And I guess, again, from the perspective of medical school admissions, there's not enough seats in states that are safe. You know what I'm saying? To accommodate absolutely everybody. And so I could see how people would say, well, I'm going to apply here, or I'm going to apply there. It's such a conundrum. So we're coming to the end of the time. I want to give everybody a chance to kind of make a final statement or comment to the group. So Katie, I'd like to start with you. What would your kind of take home be for this amazing session?
I think it's so exciting that these conversations are happening, and that people are interested and motivated in talking about our experiences and how they've shaped us and led us into this work, and how we can expand outward and increase access to really good quality LGBT affirming care for everyone who needs it. And I'd love to see more dialogues with more varieties of folks and a longer table to include all the voices.
Fantastic. And then Allison, how about you? What would your final words be of wisdom?
Sure. I would say if you ever get invites to participate in research, to maybe do it, because I think the data are so critical to collect, and we really don't have enough, on queer, trans women, and non-binary people. So if you do see some research coming out related to health issues or any other kinds of research, I think I would say absolutely participate. That way more data can be gathered and your life experiences could be known. And then that hopefully is what drives any kind of practice changes.
I guess I get to go last.
You get the final word.
Well, I want to thank Dianna for her art. I think that these opportunities really remind us of the incredible value of art and artists and what they do and what makes it all worth it, and a space to create for us to talk about it and to have captured all of these beautiful and poignant and sometimes sad, but sometimes great things. And I just feel like we don't give art enough love. So thank you, Dianna.
Thank you. I'll piggyback off of that and say also, whenever we do these events, I just have to thank the folks who interviewed and the people who were behind the camera, who were really diligent and thoughtful in reviewing the film and offering advice and connections and stuff like that, because you can't make a film without people who are willing to be really generous and vulnerable, and also proud of themselves and what they have gone through and what they have achieved. And what they have done for other people, knowingly or not. And so I couldn't be here without them. And it's a great privilege to be able to carry those stories out into the world, into educational spaces like this one. So thank you all for having me and for having them.
Amazing. So again, thank you for attending this 2022 WeHo Pride LGBTQ Arts Festival presentation of Patient No More. And we hope to see you at other events. Thanks a lot.